Okay, our speaker tonight, Dr. Rich Lawton, will discuss one of the most common causes of disability in the senior population, knee pain. He will define the multiple causes and surgical and non-surgical treatments with illustrations to clarify the discussion. Dr. Lawton is a graduate of the Emory University School of Medicine with a 5-year residency in orthopedics at the Mayo Clinic and a PhD in industrial psychology from DePaul University. He specializes in joint replacement of hips, knees, and shoulders, and takes care of a broad array of problems, including arthritis, injuries, and fracture care. Dr. Lawton, if you'd like to go ahead.
All right. Well, I'd like to thank Joyce and Carol and Bill for helping me out tonight, getting things coordinated. Super helpful. And welcome everyone to what I hope will be an informative talk, and we'll have time for questions at the end, I think. And so jot things down, make notes so we can get to all of your concerns or questions eventually. So as you can see, the topic of this discussion tonight is knee pain, causes, cures, and prevention. I grew up in Fullerton, California, and my dad, Joe Lawton, and my brother, Ted Lawton, are still active members of the medical community there, and I visit frequently, but my current practice has moved to Western Nebraska, although I still have a home in Durango, Colorado, so I'm a bit all over the place. The goals of tonight's talk are, we're just going to give it the straight skinny. We're not trying to sell anybody anything. We're not going to try to sugarcoat anything because we think that's what you want. We want to identify warning signs of different causes of knee pain, so you as a patient can be aware of these things as they start to arise in you or a family member. We want to identify the solutions. We want to know what works and identify what does not work, equally important. The causes of knee pain, we know there are many things that can make our knees hurt. Our knees are like any other machine, essentially, like a car. And like a car, there are different types of parts, and these parts can wear out. They can tear or fail in some other ways. They become inflamed or break, fracture. A few common causes of knee pain that we'll get into later in the talk in greater detail include tendonitis or bursitis, strains and sprains of the things around inside of our knee, tears of structures inside the knee, like the meniscus, as shown on this picture. Here's a model of a knee that has a meniscus tear. We'll go into that in greater detail. Fractures of the bone can fail as well. You can break your bone. You can have develop a chronic condition that can progressively deteriorate over time. That can generate knee pain. So things like arthritis, illustrated in this picture over here. We'll go into greater detail about that. Loose bodies, that means loose pieces of bone or cartilage floating around inside your knee, like a rock in your shoe. Those things can catch and generate pain. We'll talk about all that stuff. Things that are red herrings, we're not going to spend much time on because you may be familiar with some of these terms, but very rarely are these things causes of pain. So don't hate me for not covering things like Baker cysts or bone spurs in a tremendous amount of detail. We do know that these things are real entities inside of knees, many of which have pain, but usually these things such as Baker cysts and bone spurs are the consequences of a different underlying painful condition, such as arthritis or a tear in the meniscus. This MRI slide shows somebody who has a Baker cyst. This white circle here is a cyst behind the bone of the femur and the tibia here, and usually occurs in the presence of a torn meniscus that allows the joint fluid to get squished into this. So in this setting, that means the Baker cyst, while easily seen on an MRI, is not the cause of the pain. The meniscus tear is. So we're not going to spend a lot of time otherwise on these other topics. Other things we're not going to cover will include things that are very rare, the unicorns, the zebras. We're not going to spend much time on that. Instead, we're going to talk about more common things. So for example, this is an x-ray that shows bad tumors affecting the distal femur near the knee, we're not going to spend much time on that. Naturally, if you have one of these, you'll know it, and that'll hurt for sure. And then there are a long list of very rare genetic conditions that can generate knee pain. We'll not spend any time on that stuff. We're going to focus on more common conditions that will affect the people attending this conference. So a little brief primer on anatomy. The knee consists of bone. The bone is the femur, the thigh bone, the tibia or the shin bone, the kneecap. That's part of the knee joint too. The fibula, the smaller of the two bones in the lower leg, is not technically part of the knee, but right next to it. The ligaments that connect bone A to bone B, there are 4 big ones around the knee. The MCL connects this part of the femur down to this part of the tibia. The ACL, the thing the football players and skiers tear, that's inside here. PCL is its neighbor right next to it. LCL on the outer part of the knee. All these things can fail, can break, and therefore can generate pain. The meniscus is, we each have inside of our knee these 2 little pads that are not cartilage. They're separate from the cartilage. Cartilage coats the end of the bone. The meniscus is a pad. We have one on the inside of our knee called the medial meniscus, one on the outer part of the knee. Those things can fail. They can generate pain if they tear. The cartilage I just mentioned, coating the end of the bone on this cartoon, and this is an anatomic photo of a cadaveric knee showing the ends of the femur coated with relatively normal cartilage. It's nice and pearly white like a cue ball. That's normal. That can wear out or fail or be injured. Other relevant anatomy components include the joint lining or synovium. The synovium is the seaweed-like stuff that coats the inside of all of our joints, our fingers, elbows, knees, and that makes the joint fluid. That can be irritated or inflamed, and a host of different conditions generate pain. The tendons that connect the bones and the muscles, like the quadriceps tendon shown here, which connects your quadriceps muscles to the kneecap, that can be the source of pain. And then the nerves and the arteries that go around the knee in this very complex network, those can occasionally have problems that generate pain. That's rare. We won't spend a lot of time on that. So in summary, the point of reviewing that briefly and quickly was just to illustrate that there are lots of different structures around and inside the knee. These structures interact with each other. They are not bomb-proof. They can be damaged. They can blow up. If you expose them to enough force, they can wear out like the tire on your car. They can become inflamed and irritated, or they can develop an abnormality like the bubble on a tire. And all of these things can generate pain in the knee. So the challenge is to sort through those things. If you're someone who's experiencing pain, is to know which of these maladies is at the core cause of your pain. So we have to sort of pick out how we're going to get through this. And I think the best path for us tonight is just to sort through these things by the frequency with which they're observed in the knee. So we're going to sort of go through things from most common to least common as we get through the talk. So we'll start there with a discussion of tendonitis and bursitis. Tendonitis, itis tacked onto the end of any medical term means inflammation. So you have tendonitis, that's inflammation of a tendon, or bursitis, that's inflammation of a bursa. We'll go over what those tissues are here. And inflammation sort of has a bad rep these days. It's associated with other things like heart disease, and but we do know that inflammation in many ways, in most occurrences in the human experience, is a normal response. When we work out, when we have an injury like a bruise, the initial response to that is inflammation. However, it can get out of hand. Inflammation can. Normally it lasts just a couple weeks after an injury. And if it becomes pathological and persists, that is abnormal. So a couple examples of that are patellar tendonitis or quadriceps tendonitis. Those are conditions in which the tendons in the front of the knee get inflamed. And it's especially noticeable with pain in the tendon, not in the bone, with resisted use of the knee, such as descending stairs or going downhill. Best way to diagnose that is to have an insightful, thoughtful physical examination by someone familiar with the knee. Imaging such as x-rays or MRI can be helpful. Oftentimes they're normal. I selected this slice of an MRI looking at a knee from the side, where you see here the femur, the kneecap, the tibia here, and these black structures up here in the front are the tendon. This is the quadriceps tendon going from the quadriceps muscle to the upper part of the kneecap, and then the patellar tendon going from the kneecap down to the tibia. And this black part of the tendon is normal. That's what you want it all to look like. And you can see this part of the tendon doesn't look like the rest of it. That's because it's chronically inflamed with chronic patellar tendonitis. So the imaging, MRI in this case, can be helpful in the diagnosis. The treatment of tendonitis, whether it's or bursitis, usually is non-surgical. Almost never is a surgeon operating on tendonitis. Usually the components of non-surgical treatment include just waiting it out, just time, resting it, medications, physical therapy. Physical therapists have these fancy devices like ultrasound, ice, electric stimulation, and other tools in their magic belt, their Batman belt, to apply to you and your inflamed tendon. They are usually quite effective. So you can rest. Modifying activities, the medications I mentioned earlier in greater detail will include over-the-counter anti-inflammatories. These are the ibuprofen formulations, and then OLLI-Live is a cousin of ibuprofen. So these are sort of the provide the bulwark of pain relief in patients who have tendonitis. You can add to that Tylenol. They're safe to take together, Tylenol and the anti-inflammatories. They're like ice cream and chocolate sauce. They're both good. They're even better when they're together when treating tendonitis or bursitis. Topical treatments such as topical ointments or lotions that you can buy over the counter at your market, at the pharmacy, Walmart, those things can be very effective as well. Stretching, physical therapy we mentioned earlier can be quite helpful. Ice is your buddy. Acupuncture supplements, we're getting a little bit outside the mainstream here, but some patients will swear by these treatments. There's not a lot of data to support their use, but some patients will have very good outcomes if you add these adjuncts to regular, more conventional treatments. As the symptoms start to improve, the patient is usually encouraged to get back to their activities, including sports and other vigorous outdoor activities that they're interested in. And then as your symptoms tolerate return to activities, then you can get off the medications and any other treatments that you've used to get over the acute symptoms. Prevention of tendonitis and bursitis is there's quite good data on this. And the keys are to not dramatically increase one's activities. Don't go out and train for a marathon by running a marathon right away. We do know that tendons and bursa tissue respond to load. Slow introduction of the loads over time is better than applying too much load quickly, which can lead to inflammation. Here's a graph from a paper. It's a little complicated, but what it says is if you are able to apply small amounts of stress, represented here on the halfway up the y-axis on this graph, then your tissues can accommodate that. They'll have some microscopic failure, but they will improve their strength over time. But if you exceed this load and you apply too much stress, that's when you run into the tissues becoming chronically inflamed, damaged beyond repair sometimes. So the bottom line, the take-home point is ramp up slowly in terms of the mileage, the speed, your terrain, the company you're keeping. Keep away from guys like this. This guy his intent is to hurt you. Find somebody a little more gentle. Getting away now from bursitis and tendonitis, we'll talk about another common cause of knee pain. Those are sprains or contusions of the tissues around the knee. These are usually generated by trauma that can occur when you step in a hole, when you have a cutting or pivoting injury. This is Barry Sanders, probably a lot of you guys might remember him. Having a wipeout, of course, car wrecks, falls from height, all these things can generate too much load for the tissues in and around the knee. Of course, that would be associated with immediate pain as those tissues fail. This is an MRI slice showing injury to the MCL on the inner part of the knee. Right in here. Sorry, that's my phone. Let me get rid of that. Sorry about that. So this is an MRI looking at the knee from the front, where this big black structure here going from the tibia up toward the femur is the MCL, the medial collateral ligament. It's a ligament that can be commonly injured with a trauma, and it sort of has pulled off the bone. Normally, these black fibers are intimately integrated into the bone of the femur, but in this case, they've been sprained or torn, pulled away from the bone. Naturally, if you experience that, that's going to hurt straight out of the chute. The treatment for many sprains and strains, contusions around the knee, thankfully, is non-surgical. Usually that works quite well. For example, if you have an injury like this to your MCL alone, usually those patients do well after about 2 to 6 weeks. Get them in a brace, give them some time. Usually this will heal back to the bone with normal function. And then as things start to heal, you can slowly reintroduce those patients and their knees back to their activities of choice. Physical therapy can be part of that recovery. Sprains and strains, just a little technical jargon. Ligament, again, I think I went over this briefly, but just to be absolutely crystal clear, will connect one bone to another. For example, the femur to the tibia. Here's a cartoon illustrating what we saw in the prior MRI. This is the medial collateral ligament. It goes from this bone, the femur, down to this bone of the tibia, and you can tear that bad boy with just the too much force. Here's a view of a knee from behind. We're looking at someone from behind the knee, and this shows all the hamstring tendons, and you can strain your tendon or develop a little tear in your tendon. A tendon will go from the muscle, this is represented here by this muscular looking tissue, all the way down and attached to the bone. You can tear that with trauma. So again, the mechanisms are usually a twist or fall or eccentric load to the joint. The training, again, the training of the tissues around the knee, the ligaments, the tendons usually responds well to stress over time. Here is part of a research article that I like to cite. The bottom line is that the strength of your tendons and your ligaments decreases if you're inactive. So if you're a couch potato, or you've had a recent injury, you've had a recent stroke, some other medical problem that caused you to be inactive, the tissues are getting weaker over time. The good news is the strength of those tissues can be restored or improved with increased chronic activity or training that's of an endurance nature. So that's a good take-home point. Your fate is to some degree in your hands with prevention of these types of injury. Certainly, we're not bomb-proof. We're not superhuman. There's a limit to what we can accomplish with training. However, it's still a good idea for people who are interested in minimizing their risk. The use of braces for activities is a bit controversial. There maybe is a weak effect for decreasing the severity of knee injury in football players, but other than that, routine use of braces for joints that are otherwise normal, especially, doesn't seem to be of great value in terms of injury prevention. We'll move on now to inflammation of the joint lining or synovitis. The synovium, again, is the joint lining. We have that in all of our joints, including our knee, and that can get irritated with overuse. We see it a little more commonly in patients who have chronic inflammatory conditions such as rheumatoid arthritis and its cousins, things like lupus. This is an arthroscopic picture of joint lining. These fronds or the joint lining are red and inflamed. That's abnormal inflammation. That's what it looks like in real time, in real life. We also see occasional inflammation in adolescents as they're growing. Their joint lining can become inflamed. This is a typical patient who's more likely to get adolescent synovitis in their knee, or patellofemoral syndrome is one of its monikers. It's usually a younger female, more likely than male, and the inflammation is usually the only problem. There's no cartilage loss, there's no tearing of any tissue. And the correct diagnosis of synovitis, you need a good doctor, a doctor who's good with knee stuff. You don't want Turk and JD looking after your knee. Often the x-rays, MRIs, and other studies are normal in patients who have synovitis or inflammation in their knee. If you have a rheumatological condition, oftentimes the blood tests in those scenarios are abnormal. RA means rheumatoid arthritis. Sorry about that. I'm using too much jargon. The treatment for synovitis is typically non-surgical, depends on the cause. We treat different causes a little bit differently. For example, rheumatoid arthritis patients are typically treated with medicine by a rheumatologist or a primary physician. Patients who have synovitis who are adolescent athletes, we treat them oftentimes with rest and over-the-counter medications. Sometimes some physical therapy can help settle down the inflammation as well. Occasionally, we'll use a little brace for patients who have synovitis around the knee, especially adolescents. Cortisone injection can be super helpful in patients who have synovitis of any cause. Cortisone is a very potent anti-inflammatory, and you can inject that directly into the knee. It's like dousing a fire with flame retardant or fire extinguisher. Can really knock down problematic synovitis. Now we'll get into stuff that's probably common among people over the age of 50, aggravation of conditions with activities, specifically arthritis. Arthritis defined as the loss of cartilage. The loss of cartilage, here we have a picture showing a normal knee on your left and an arthritic knee on the right. The normal knee has this pearly white cartilage we saw earlier in the talk. And in arthritis, that cartilage wears away and you're left with exposed bone. This bone should be covered with cartilage. It's not. That generates pain. Here's an arthroscopic photo showing the same thing. This is the tibia. This is the femur. When we look inside the knee with an arthroscope, and the cartilage, this is relatively normal looking cartilage, and that cartilage should extend all the way over here. And you can see this part of the tibia has no cartilage left on it. This bone that used to be covered with cartilage is now exposed, as is this bone on the femur. And when you have bone rubbing on bone, that's much higher friction, 1,000 times more friction than smooth cartilage on smooth cartilage. And it's that friction we think that changes how cells behave, the number and types of cells inside of the knee joint that generates inflammation, and with inflammation comes pain. Over time, the bone can erode, and you can see this knee is a little bit bow-legged. This is a normal knee here, but as arthritis worsens and the cartilage that coats the end of the bone wears away, things can get out of alignment and cause these deformities we see in patients with bad knee arthritis. I'm not sure why I put this hiking and running. Usually patients notice arthritis pain when they're hiking, running, doing other vigorous weight-bearing activities initially, and they say, well, when I ride a bike, it doesn't hurt me so much. So if you're having symptoms that are worse with cutting, pivoting, running, vigorous hiking, even walking longer distances, going downstairs, that can be arthritis. And when you do less weight-bearing activities, things like bicycling, swimming, the knees tend to tolerate those pretty well. The best way to diagnose arthritis is to have a knee provider, somebody who sees knee pain commonly. That can be a family medicine doctor or a rehab doctor or an orthopedist. X-rays will often show the arthritis. This is a normal X-ray and an abnormal one in which the patient has arthritis, again showing a bit of bow-legged deformity. Here's how a bow-legged deformity shows up in real life. This patient's left knee is relatively normally aligned. You can see the side-to-side difference there. Sometimes we'll see little bone spurs sort of growing out on these little stalactites growing out the side of the bone in patients who have arthritis. The MRI will show pretty much the same thing. MRI shows us a little more detail. The cartilage that normally coats the end of the bone here is worn away. There's some gray cartilage. That's this gray stuff over here in the outer part of this patient's knee. And on the inner part, that cartilage is totally worn away. And on the MRI, you'll also see fluid inside the bone. That is, when you get an MRI of somebody's bone, the color should all be the same. It should all be this color on this particular series, all this gray color. When we see this white discoloration of bone, that means there's fluid in the bone. That's edema is the term we use for that. And the only time we typically see that is with injury or arthritis. That's typical MRI finding in the arthritic knee. Sometimes in the MRI in patients who have arthritis, you'll see these concomitant pathologies. You'll see patients who have meniscus tear. This guy's got a meniscus tear right there. Loose bodies, loose pieces of bone or cartilage floating around in the knee. Those are sort of the usual suspects that tag along with arthritis. The treatment for arthritis is a huge topic. We could spend a long time talking about this alone. There's a whole spectrum of cost and risk that goes from not very much to quite big. In general, when the arthritis is mild, as we see here, this is the spectrum of arthritis going from normal all the way to severe. When the arthritis is sort of on this end of the pictures, then usually we can achieve good pain control with things that are safe and cheap for the patient. By that we mean things that are like Tylenol, over-the-counter medications, sometimes cortisone injection. And as you get in here, the treatments become more expensive because the cheaper things simply don't work anymore. The severity of the problem is too great for Tylenol and medications, other things to work. So we have to go up the ladder, so to speak, use things that are more expensive. And then when things get bad and the arthritis is severe, we have to think about surgery because the other things simply are not working. Arthroscopic surgery and knee replacement being the main topics of interest here. And of course, those things are expensive and have more risk than a Tylenol. If you have arthritis is mild, one of the first things out of your doctor's mouth will be you can rest. And of course, most patients laugh about that. They're like, I have things to do. I'm not here at the doctor's office because I want to rest. I want to get after it and I want to be active. So we have to mention this more out of the sake of being complete and informing you, but we know that that doesn't go very far. Over-the-counter medications, sometimes hiking poles, supplements are a bit of controversy, things like turmeric and garlic, those sorts of things. People want to try that stuff off, and there's not a lot of data to support it. Injections, you can have things injected into your arthritic knee, cortisone. Then there are these other gel products that can be injected into the knee. Some people hear that called rooster comb. These sort of products, they're not going to cure your arthritis. They may make you feel better in the short term, so they're worth a try, but they're certainly not a cure. The use of stem cells has gotten a lot of publicity lately, and we get a lot of questions about that. I'm sure we'll have questions after the talk is over about stem cells, which is appropriate. Stem cell treatment. Currently, the best way to summarize what we know about stem cells is the benefit to the patient currently is questionable at best. Here's sort of an illustration which you can take cells from somebody's fat, culture them, inject them back into the knee after a bit, or you can take cells from an umbilical, blood, or other sources, inject those into the knee. And the theory is those cells will somehow magically migrate to where the area where the cartilage has worn away and produce new healthy cartilage, or go to the joint lining where they'll decrease inflammation. Most studies in the long run don't show much benefit. There are reputable groups looking into this now in greater detail, including the Mayo Clinic, but the studies yet are not complete, and the studies that do exist don't show much benefit or are of questionable quality. Certainly, we don't consider these stem cells to be anything that has been shown to reverse arthritis. We're not been shown to generate new cartilage. They might decrease inflammation a bit, much like cortisone does. It is tempting for patients who have arthritis because nobody wants surgery. We certainly understand that. I'm an arthritis patient myself. I didn't want surgery, so we're looking for answers that are easier than surgery. We certainly get that. We want to regenerate, renew. That's part of our culture, especially these days. We have to be careful because we are, as arthritis patients, a vulnerable group of consumers, and that's how we're viewed by companies who are out to make money on us and take advantage of our fears and anxieties about other treatments that we may not want. And so there's considerable marketing and profiteering going on. We have to be aware of that. Hopefully it will evolve beyond that. Hopefully these will prove to be useful, viable treatments down the road, but currently we're not there. In summary, stem cells are unproven, more to follow. We'll get back to that, I'm sure, after the talk. Knee replacement is the workhorse for patients who have end-stage severe arthritis, many of whom have been through the trials of medicines and injections, cortisone, these other things. The numbers in the US are going up, and this was a projection made back in 1996, and we're pretty much on track. Currently, 700,000 are performed in the US every year. These are worldwide projections. 85 to 90% of patients who have a knee replacement in the end are happy with their result. We do know that knee replacements are quite durable. The recent studies show that most of them last well beyond 20 years. The nature of knee replacement surgery consists of resurfacing the bone. Here is a model looking at a knee from the side that shows the observer how much bone is removed. We remove about a half an inch, about 8 to 10 millimeters off the end of the femur, the front and the back, same amount off the underside of the kneecap and the top of the tibia. We put new surfaces on there. So here's an illustration. This is an illustration of a knee before and after knee replacement, showing the cap that goes on the end of the femur, top of the tibia, underside of the kneecap. The surgery takes us about an hour and a half to do for somebody who does a significant volume. Typically, patients are in the hospital one night, give or take. Some patients are being done same day, outpatient surgery. I'm not sure that's good for everybody. Some patients need to stay a little longer than that. Total recovery before patients are back doing all activities they have interest in is 2 to 5 months. It's a little bit on the longer end if you're into vigorous activities that require lots of durability and strength. If you just want to walk around the house, and certainly you're doing that by 1 to 2 months out from surgery. We recommend after knee replacement, the patients can participate in any activities in which they have interest. That would include skiing, hockey, golf, tennis, walking on the beach. We're not really interested in our patients doing distance running, although I've had a couple of patients who've gotten back to distance running against our recommendations. They seem to be just happy as a clam. Recent data shows that you don't wear their knees out any faster than anybody else. The surgical treatment of arthritis occurs after non-surgical treatment fails. There are other operations aside from knee replacement. This is an arthroscopic photo showing something called a microfracture surgery, in which we stimulate new cartilage to form. You can tell most of the cartilage in this patient's knee looks good. Here is the cartilage on the tibia. That looks pretty good. Here's the cartilage on the femur. It's got this big defect in it, and we use this pick to make holes in the bone. After we make about, I don't know, we probably make 8 or 10 holes in this bone here, then it fills with a blood clot. This is that same femur about 4 minutes after all these holes are made. And that blood clot over time can turn into new cartilage. We know that that surgery works well for patients who have small areas of arthritis involvement in their knee, which is not common. Most patients who have arthritis, the whole area of the femur and the tibia has totally lost all of its cartilage. And we've learned the hard way that this sort of surgery for patients who have experienced broad swaths of cartilage loss, usually not, this surgery is not very effective for that cohort of patients. Those patients, as we mentioned before, can undergo a partial or a full knee replacement and experience a good outcome. This is an illustration of the difference between a full knee replacement and a partial. If you have arthritis just on the inner part of
muting and
Hi, Dr. Lawton, can you hear me? It seems like your computer has locked up.
so bring up.
Looks like he dropped out.
Yeah. Hopefully he'll log
Yeah,
back in.
Back in. Zoom has been really unstable recently.
Yes.
Should we ask people to put questions in the chat if they have any.
Yes, this would be a good time to do that.
Yeah.
If you have any questions, please type them in the chat, or when Dr. Lawton finishes, if you'd like to ask the question live, you can raise your Zoom hand. Wonder if I should give him a call.
And yeah, give him a call on the phone.
While we're waiting, we have a guest here named Clarence L. I wonder if you could put in your last name, and if you don't know how to do that, unmute yourself and let me know, and I'll do it for you.
He's trying to log back in. He said his Wi-Fi just dropped.
Yeah. Okay.
You just click on your name and down at the bottom it says rename.
Yeah. Can you do that? Clarence, can you tell me what your last name is? He's back.
All right, sorry about that. The foibles of,
Yep.
all right. Let's see, where were we? Okay. All right, can you guys see my screen?
Not yet.
Oh, do I have to share screen again?
Yeah. Or we may have to make you a co-host. There you go.
Share screen. How about now? Can you guys see that now?
Good, good.
We're good?
Yeah.
Okay,
You may need to run your PowerPoint though.
yeah.
Okay. There you go.
So I can't remember where I left off with where it got dropped. We go over partial and full knee replacement?
You were doing partial.
Okay, great, thanks. So the difference between a partial and a full is sort of illustrated over on this side of the slide. This shows a full knee replacement in which the entire femur and top of the tibia have been resurfaced. And this, what's that? Oh, sorry. And this shows a partial or unicompartmental knee replacement in which this part of the illustration shows normal anatomy. This part over here shows a cap on the end of the femur, a cap on the top of the tibia. It's a little shorter recovery, a little smaller surgery, more likely for those patients with a partial to consider their knee to be normal. There are a couple other trade-offs. The risks of a knee replacement, partial or full, are significant, but they're usually rare, thankfully. They include things like dislocation, infection of the parts wearing out over time or loosening from the bone, developing blood clots, having nerve damage. Those things are extremely rare, but real disasters for patients who experience them. So naturally, the people often wonder, well, geez, that sounds like no fun for me. I don't want arthritis. What can I do to avoid it? So it leads to a discussion of what causes arthritis. And a big part of that is genetics, just like some of our other body morphological characteristics. Genetics play a role in our risk for arthritis. Some of us are born with a 20,000 mile tire cartilage that's going to wear out quickly. Other patients have cartilage that's super durable, and that's just genetics. The other risk for developing arthritis is injury. If you have a bad ACL injury or other ligament injury, bad injury to your cartilage or meniscus from a trauma, those are definitely risk factors for developing arthritis down life's road. So if you can avoid injury, you'll decrease your risk for arthritis. And then the most modifiable risk for arthritis, the one that's especially pertinent today, is obesity. Our knees are meant to carry physiologic load, the load we were sort of designed to tolerate. If you put too much load through a little tire, this is not going to work out, and this tire is going to fail. Same thing goes for cartilage that's exposed to excessive forces. So naturally, that's to avoid arthritis and avoid obesity, puts a premium on having the right diet and exercise and all these other things that we all know. We're not going to get too much into that. People worry that their activities are going to put them at risk for arthritis, things like running or walking or skiing. And if those activities are taking place and you're not injuring your knee, those are healthy for our knees to do. There have been many studies looking at, for example, the risk of running contributing to arthritis, and there's no risk that running of any amount or type, whether that's marathon or 5K or just around the block, will increase your risk for arthritis. There's no relationship. To some degree, our knees were designed to run away from things, run after things. You can imagine historically and ethologically, or in a Darwinian sense, cartilage that can tolerate running is more likely to survive over time and may have some protective effect, in fact. Meniscus tears, another very common cause of knee pain. Meniscus anatomy. Here's sort of illustration of the femur here and the tibia. And if you take a close up of that, where this is the bone of the femur and the tibia, here's a slice through the meniscus. It sort of extends part of the way across. It's like a disc or a crescent that we have one on the inside, one on the outside. This illustration was chosen because it shows the blood supply to the meniscus. This part of the meniscus has a blood supply. This part does not. And the reason that's significant is it's very unusual for us to have inside of us a tissue that doesn't have blood supply. Our bone has good blood supply, our tendons have blood supply, our intestines have a good blood supply, but this part of the meniscus does not. And so that becomes relevant in that if it doesn't have a blood supply, it can weaken with age, just like the sole of your shoe or the tire on your car. And eventually it can fail, and it can be sort of degenerating or weakening silently. And then you take your 1 millionth step or pivot, and it gives way under that stress. This is an illustration of different types of meniscus tear. You can develop one of these radial tears, or a tear that sort of extends along circumferentially like this, or a parrot beak tear. Here's a picture of an arthroscopic surgery in which you see this flap of torn meniscus tissue pulled away from where it used to be before it tore. Patients who have meniscus tears will have pain, usually right where the tibia and femur come together. We call that the joint lining. That pain usually is worse with pivoting or squatting. Sometimes patients will report catching or locking. Their knee locks in place or snaps. Those can all be signs or symptoms of a torn meniscus. Treatment of meniscus tears, we can divide that up into non-surgical and operative. Usually non-surgical treatment is not very effective because, again, the torn part of the meniscus doesn't have a blood supply, so it doesn't really have any healing potential. Cortisone injection might provide some benefit in the short term especially, but typically when the cortisone wears off, the pain comes back, requiring patients to sort of consider surgery in which either the torn piece of meniscus is repaired or trimmed away. It's like removing the rock out of your shoe. If you all had rocks in our shoe, boy, that hurts. And if you just take the rock out of the shoe, the pain goes away. Same holds for trimming up the torn piece of meniscus in the knee. So here are some illustrations of how that works. Here is this represents the meniscus tear here, and we can get in there with these little biters and nibble away the torn part of the meniscus, leaving the vast majority of the meniscus intact. So here's sort of a before and after photo, nice clean edge of the meniscus. We just did one of these surgeries today. Very common orthopedic surgery. Recovery from that surgery is short. It's usually an outpatient, all arthroscopic surgery. Patients are back doing everything they want, including playing NFL football within 3 weeks, typically. Tendon tears, this is less common, but certainly a known entity that comes into our office from time to time. Usually these injuries occur acutely. occur right away and more likely in men than women. Usually the age group most susceptible is late 40s to early 60s. Usually occurs when people have an awkward step off of a deck onto a dock, or they jump off of something. They'll have immediate pain. They'll have a defect where they can't, you'll feel where the tendon is pulled apart, and they have weakness and usually straightening their leg out. The diagnosis is quite clear often when we see the patient from across the room, but the MRI will show the tear clearly. Here's looking at an MRI of a knee from the side, where this is the femur, the tibia, here's the kneecap here, and here's the tendon. The quadriceps tendon has pulled off of the kneecap, has torn away. All this white stuff is the fluid or the bleeding from that torn tendon. The treatment for that is repair. These illustrations show that how we can repair a quadriceps tendon that's pulled off the bone, or patellar tendon that's pulled off the patella as well. Usually these heal up normally and the patients get back to all activities in which they have interest. Recovery can be a bit long. It takes a while for a tendon to heal to the bone, but usually we get the patient there. ACL tear is very much the bailiwick of any knee doctor. Anyone taking care of knee patients will see a torn ACL. The ACL is this big ligament inside the knee that runs from this part of the tibia up to this part of the femur. And like other tissues in our body, it has a limit of what it can take. If you have an awkward twist on a planted foot, like is illustrated in this female basketball player, the knee can buckle in like that and cause the ACL to tear. Skiing, football naturally are other high-risk sports for ACL tears. Usually patients who have this injury will report a pop with a pivoting mechanism, immediate pain. They can't get back to their activities. They have immediate swelling. The diagnosis is usually cinched with the MRI, shows it quite clearly typically. ACL tears are not cancer. They won't kill you. And if you're a low demand athlete, you want to ride a bike and walk, sometimes you can do more aggressive things if you have a torn ACL. But if you want to get back to cutting and pivoting sports, usually the torn ACL doesn't heal well on its own. So if you want to get back to cutting and pivoting sports, a surgery to remake or reconstruct the ACL is required. Here's arthroscopic photo showing a normal ACL here, a torn ACL where it's all jumbled up, pulled off the femur. And this is what it looks like at the end of the ACL surgery, in which we've remade the ACL from a tendon graft. I prefer to use a tendon from the patient themselves rather than from a cadaver. The success rates and re-tear rates are better if you use the patient's own tissue compared to cadaver tissue. Here's an illustration of what the ACL surgery consists of. We drill a tunnel into the tibia and another one into the femur, and then we lace the graft in there and fix it with hardware of one type or another, such that this tendon now lays where the ACL used to be before it tore. Success rates of that are high, and recovery is a good 6 or 8 months. This is Tom Brady, of course, that cute little devil. He had an ACL tear a few years ago. Lindsey Vonn has had 2 ACL injuries. Both, of course, were able to return to greatness. Patients who are at risk for ACL tears include younger males. We worry about patients are more likely to develop arthritis if they don't just tear their ACL, but also at the same time of their ACL, if they have a meniscus tear or cartilage injury. That's a different group of patients who have a poor prognosis in terms of risk for arthritis down life's road. So in summary, knee pain is common. It's one of the most common things that we see, as Carol and Joyce noted at the beginning of the topic. One of the most common reasons patients will come into the orthopedic doctor's office. There are many things that can cause knee pain. All of us are just between falls. We have to remember that we're all just between injuries. There are some things that we can do to prepare ourselves, minimize our risk for injury and knee pain, training appropriately, warming up before we get out on the trail. To treat knee injuries, there's a whole spectrum of treatments, as I think we summarized. If the injury is relatively mild, you can medicate it and rest it. If the boo-boo sort of things, contusion, sprains, strains will heal up great. You don't need a surgeon for that, thank goodness. And trust your judgment, though. If something's taking longer to heal up than it should, something's been painful for over a month or two, Usually sprains and strains will heal up within a month or two. So if something's taking longer than that to heal up, then maybe it's because it's not a sprain or strain. You might have a tear of something or arthritis. And if you're suspicious of those things, you should get it checked out so you can know what's going to work for you and what's not going to work. All right, so that is the talk.
Dr. Lawton, would you like me to read the questions that are in the chat, or do you
Yes,
prefer
ma'am.
to?
That'd be super duper.
Okay, and also, if anyone would like to raise their Zoom hand and ask a question in person, feel free to do that also. Okay, the first question, what are effective exercises for the pre-arthritic knee?
I think any activity in which the patient has interest are effective. So whatever you like to do. I think walking is probably number one on the list. Hiking is walking, but just in a prettier space. Light running, people who are into running, people who are into golf, tennis, any activity we think that keeps your joints moving and keeps your joints lubricated, keeps the tendons and the ligament.
Oh,
So Dr. Lofton, could you stop sharing your screen so we can see you when you're responding?
I think he might have frozen up again.
Uh-oh, yeah, I just saw that. I was hoping that if he could stop his PowerPoint from showing, it might give him a little more leverage.
Yeah, I'm sure he'll notice that I hate to call him again because he realized he was lost last time.
Right.
Maybe you can text him.
Well, I think he knows that,
Yeah.
that we lost him.
Has he dropped out? Let's see if I'm in.
He's just frozen up, it seems like.
Yeah. I know he dropped out.
Yeah. Bill? You lost Dr. Watt. Did you come back in?
Taking him a while to get back.
Consider just having him call it.
This is a point where we start doing shadow puppets on the wall.
Well, I got a lot of good questions here.
Joyce, is this being recorded?
Yes, it is.
Oh, good. Okay. Thank you.
And there'll be a YouTube recording of this
Mhm.
that you should be able to access after the session is over.
Okay, great.
He's trying to reconnect again. He realizes that he
Oh, he had dropped out.
lost his connection. Yeah. But it might not be him. As you said, we've been having trouble with Zoom.
He may need to maybe update it. I don't know. Somebody said there was an update today.
Oh,
The last update was very unstable.
yes.
Yes,
I should
yes,
have.
I'm on last week's update and my PC froze shortly after we started the stream.
Oh, today?
The live stream today. Yeah, so I have a PC
Uh-oh.
that's locked up here. And I had to switch to my iPad.
Yeah. So maybe the update is not a good thing to do if you haven't had a problem. Here he is.
Oh, he's coming in.
Yeah. Poor guy.
All right.
You're back.
You're a real expert on this. Okay.
Yeah.
All right. I went through my mobile hotspot now, so assuming I continue to have cell service, we should be good.
Okay. Let's see. What type of conditions are characterized when pain primarily occurs climbing stairs?
Yeah, so it's typically arthritis. It can be a meniscus tear or synovitis. Depends to some degree on the age of the patient. Can you be more specific about the age of the patient, or is that? I would say if the patient's older, over the age of 60, usually it's going to be arthritis or meniscus tear. Sometimes a loose piece of bone or a loose body. If it's a younger patient, an adolescent, I know that's not those patients aren't necessarily part of this discussion tonight, but younger patients it's going to be different. It's going to be inflammation or patellofemoral syndrome, one of these other conditions.
Hmm. Bill, would you like to ask your question from YouTube?
Yes, we have a couple questions on YouTube. What are the qualifications I should look for in a knee surgeon?
I think I would ask, the best qualification is to ask the nurses that work in the operating room, because they know who's good, they know who's doing the surgeries well, they know who takes care of their patients before and after the surgery, and they'll give you a good sense for the character of that person. There's nothing that will test one's character more than the trials of the operating room. Most people don't have access, I know, to OR nurses, but other people like physical therapists in your neighborhood or in your community, they will have a good sense for whose patients do well, whose patients don't do well, who operates on everything, including things they shouldn't be operating on, who's conservative. Once you get outside of those sort of face-to-face recommendations, the reliability and the validity of the ratings that you'll find on health grades and these other things are less reliable. We do know that Medicare tracks complications by doctor and by institution for Medicare patients. So if you go to a Medicare website, including one of the offshoots or one of the consumer data companies called ProPublica. ProPublica has sort of harnessed the data from sources, including Medicare, and they will show which surgeons have higher complication rates, which isn't to say they're any better or worse than other doctors, but it can be an indicator of quality. For example, if a surgeon does all the toughest cases in their community with sick patients and revisions and taking care of all the complications that come through the door, then their complication rates are going to be higher. It doesn't mean that they're a poor doctor, but it can give you a sense. So I think those are the best sources of data right now.
Thank you.
There's another question. Can back problems cause knee pain and instability in the knee, or vice versa?
I would say that'd be rare. If you have a pinched nerve in your back or back arthritis, and you have a real nerve deficit because of that, making your leg weak, I suppose that would be a rare combination of pathologies that could cause your knee to feel unstable. However, we know there are patients who have a problem in their knee and they have a problem in their back. So you can have two problems. It's nice to tie it all together. Occam's razor, we do like that in medicine in general. The simplest explanation is usually the correct one. So if you're having if you're having a knee pain, knee and back problem, maybe there is some unifying diagnosis that can bring it all together. But so I'd say that the short answer is that would be rare.
Okay. And we have one more comment. Marcia would like to thank you for performing a successful knee surgery on her son in Durango a few years ago.
Great. Great. I'm glad that turned out well, Marcia. Thanks for making that comment. I appreciate it.
I have some more questions here. What to do if swelling or bulk around the joint, which restricts full movement of the knee joint ongoing? Not sure if the specific source of the injury was between pickleball and challenging hikes, but bulk around the joint persists. Orthopedist has speculated the IT band. X-ray has shown no signs of arthritis.
Yeah, I would get an MRI in that scenario. I mean, if you have swelling around the knee joint that's you're more than a month or two out from an injury playing pickleball, and your X-ray is normal, what you need is a diagnosis. And the diagnosis is going to be arrived at most reliably and predictably with an MRI. And so if you can convince somebody to order the MRI, or the orthopedist or another provider, nurse practice, family practice doc, you can get them to order the MRI, and usually that'll get to the bottom of it if you have somebody who's worth their salt reviewing those images after they come out.
What's the difference between the nano knee procedure and the standard knee replacement?
I don't know what a nano knee is. I think it's probably some variant of a uni-compartmental or a partial knee replacement, in which the parts that go in are smaller and maybe more focal to a patient that has small areas of arthritis. I don't think that's something that's considered mainstream in orthopedics. I'd be cautious about undergoing a nano knee. I'm not familiar with that term. I was just at I read the journals. It was just at our annual conference in San Diego. 20,000 orthopedic surgeons and their team members showed up there, and there's not one talk on a nano knee. So I'd be cautious there.
Okay. Walking 5,000 to 7,000 steps every day, is that excess walking?
Nope. Knock yourself out. Walk as far as you want. That's good for you. It's mind, body, soul. And again, the studies show there's no increased risk for arthritis if you walk or run, regardless of the amount of the walking or running, type of walking or running, steps, hiking, flat ground, treadmill, doesn't matter. As much as you want to do, for whatever reason, you're not going to harm your knee.
Okay. How are replacements attached to the bone?
There are two methods. One is to cement them into place. The ends of the bone, once the bone is prepared, you apply cement that takes about 10 or 15 minutes to harden. And then onto that cement that's on the bone, you press the components, hold them in place while the cement hardens. There's been a trend over the last 5 years to use uncemented components so that the bone grows into or onto. There's a little controversy around that, but those are the two main methods. They both seem to work well in general.
Okay. What's your opinion of, I will probably mispronounce this, hyaluronic acid injections?
Hyaluronic acid injection, yes. So that's the gel. Those are the gel products we brought up earlier. And can you guys still see my screen?
Yes.
Yeah. So this Synvisc syringe here, Synvisc is one of the brands of gel injections. Hyaluronic acid is the main component of that. And so there are several different companies that make a variant of that. And they're all about the same in general. They tend to make about half of patients who have knee arthritis who get the injection. If you had 100 patients with knee arthritis who got that injection today, about 50% of them would say it helped them. 50%. That means the other 50% would say, I got that gel inject, didn't help me at all. But if you take that 50% of patients who feel like the injection helped them, a significant percentage of patients will get relief out to 5 months, 6 months, even a year. That's not common, it's certainly not typical, but that bell-shaped curve extends pretty far out in a lucky group of patients. The younger the patient, the less severe the arthritis, seem to be somewhat predictive of patients who are going to experience more durable relief. It certainly doesn't regrow cartilage. It doesn't really lubricate the joint. Claims to that have been disproven. We have to be aware that this product arose out of the horse racing industry, for better or for worse. They noticed that Seabiscuit ran a little faster when they injected this stuff in the horse and said, maybe we should try this on people. That's honestly how it came out. And so its benefits seem to be limited, Doesn't cure arthritis, makes some significant percent of patients feel better for a period of time.
How is meniscus tear diagnosed? And if a meniscus tear is expected, should patient request an MRI?
Yes, yeah, MRI is the workhorse of meniscus tear diagnosis, and it will show up if it's of any significance every single time on an MRI. So if you suspect meniscus tear, MRI is a great next step. It's usually the first three, the first word out of my mouth is MRI.
We have just a few more. Can you answer a few more questions?
Absolutely. Yeah,
Okay.
whatever you guys want, yeah.
Great. Is it best to wear a brace when you exercise if you have arthritis or not?
It doesn't seem to help much. A lot of patients try a brace when they have arthritis, hoping it'll provide some warmth or stability to the knee. And usually they're disappointed. After they try it for a little bit, they find the benefit they were expecting to experience doesn't materialize. There's certainly no data to suggest it will slow the course of arthritis or decrease its severity in any way. We think it's okay for patients to try, but we are skeptical whether it's going to provide durable relief. They are cheap, they are safe, they won't hurt, but they rarely help.
Maximum age for knee replacement.
No maximum age. We'd say physiologic age. If a patient is reasonably healthy and can tolerate the surgery safely, then we can do the surgery. And so it's not common for us to do knee replacements on 95-year-olds, but I've done that before. I was criticized by, some people, but this was a person who was 95 going on 55. She was taking no medication. And her knee arthritis was so bad that it limited her ability to live independently. She was falling at home because her knee arthritis was so bad. So in many ways, it was a life-preserving surgery for her, and in my mind, worth the risk. So we did it, and I saw her at her 101st birthday 6 years after. She and her son couldn't have been happier. Which isn't to say they all go like that. We know the risks for complications go up the older the patient is, especially if they have significant medical problems, kidney, heart, lungs, diabetes, those things can increase the risk. So we get a little more worried about the older patient, but that doesn't mean we have a firm stop or firm endpoint on age. Now, some docs do. Some docs say, I won't do it on anybody over 80. I don't think that's reasonable, but that's my answer.
Okay. I have had a bubble on my knee for about 4 weeks. Was told it was bursitis. What more should I do to treat besides ice and Tylenol?
That's a great question. If it is indeed bursitis, or you suspect it is, and it sounds like it may be, I would get an MRI to confirm the diagnosis. And if it doesn't bother you, it's okay to leave it alone. But if it bugs you, you can have it removed. It's a short surgery. It takes about 10 or 15 minutes to do it. Usually it's curative. It doesn't recur. And so you might have to think about getting it removed. And the recovery from that surgery is essentially waiting for the incision to heal, which is 2 to 3 weeks before you're doing everything. So as much as none of us want surgery, if you do have problematic bursitis, it's not going away with the reasonable things you're trying, then MRI to cinch the diagnosis, and if it does prove to be bursitis on the MRI, then removal might have to be considered. I'm not a fan of injecting bursitis in the front of the knee with cortisone. Some people, I was just talking to my dad about this a couple of weeks ago. He used to sort of do it with impunity, which made me cringe. So you'll find difference of opinion among providers. Some doctors think it's okay to inject cortisone in that. I do not. So anyway.
Typical issue, knee pain walking downstairs.
Right. So the question is, what is the likely cause of that?
I think so.
I'd say, yeah, that's probably, and so I'd say the answer is very similar to the question we had earlier, which was, I think somebody asked about going upstairs. So going downstairs, if the patient's over 50, then it's usually going to be either arthritis, a meniscus tear, a loose piece of something floating around in there. If the patient's young, in their teens, that's a different subset of patients. The diagnoses affecting them are different. But those would be the top 3 usual suspects.
Okay. Can a meniscus tear heal on its own? If if a minor tear is suspected, what is the best treatment?
I don't see, there's not a huge downside to waiting it out. Usually the meniscus, since its blood supply is so poor, doesn't heal up well on its own. Back to this picture here showing the meniscus and sort of cross section. If the tear is in this vascular part where there's decent blood supply, then we think there's probably some reasonable chance it might heal. However, most meniscus tears don't occur there because this tissue is stout and thick. This is the zone of injury of most meniscus tears. Tear starts on that free edge and propagates. And so if the tear occurs in this area where there's no blood supply, its ability to heal is essentially nil. But if you want to wait it out a couple, 3 weeks, if you want, that's okay. But if it's been present, if the symptoms have been present longer than a month or two, the chance of it getting better at that point is 0. I would proceed to getting an MRI to cinch the diagnosis, be sure you're on track with that meniscus tear.
Okay, Bill, do you have any more questions in YouTube?
No, there's no more questions on YouTube.
Okay, well, I think that's it. I don't see any hands raised. So thank you, Dr. Lawton, so much for giving us your time and a great talk. And all I can say is I wish you were practicing closer to California, to Fullerton.
Well, if your patients have questions or they want me to review some of their information, x-rays or MRI, you can give my email address. I'm happy to talk to people if they're interested.
That's great.
I can help out and I'll be in Fullerton next week. So, you know, I'm just there less often than I used to be.
Okay. Well, thank you so much. We really appreciate it.
Carol, before we leave, there was one question about that he mentioned about pain when walking upstairs. What does that do to compared to going downstairs?
I'd say it's about usually the same. It's usually the same suspects are usually the cause of pain going upstairs. It's usually kneecap arthritis or arthritis in some other part of the knee, meniscus tear, sometimes a loose piece of bone or cartilage floating around in there. Usually one of those three for patients over the age of 50.
Great. Thank you.
Okay. Well, thank you so much. And for the people who are still on attending, the medical series lecture next week, the 22nd at 9 a.m. will be on rehabilitation from strokes. And just a note that the talk on back pain scheduled for next Saturday has been canceled.
Carol, we have one more question that just popped up. What causes crackle and pop sounds in the knee and there's no pain?
Oh, there it is.
There's no pain. If there's no pain, we say that's good. We can change that with surgeries. We like to say your knee doesn't hurt. Let's do a surgery so we can make it a painful knee. So in general, if you have popping or snapping in your knees, or like, you know, cracking your knuckles or something like that, is that a piece of tissue that's flipping over the edge of your bone, or your joint lining sort of popping on other surfaces, or a bit of scar from an old injury? It's probably something like that, but we don't know. And we don't delve into it. If it doesn't bother you, if it doesn't hurt, and it makes noise, your career in the CIA might be foiled. You might not be able to sneak up on people, but that's okay.
You got a lot of compliments here. You're a fabulous communicator and excellent presentation. So great.
Yes.
Thank you very much. That's very kind. Thank you.
Thank you.
I have one last question.
Uh-oh, his dad.
Can you hear me?
Yeah.
I have frequently told Rich that I'm always available for advice. And
Can you cut him off right now?
I never get a call from him that says, Dad, I have this problem.
The next 40 minutes are going to be more of the same. I'm just warning you. Could you please help me with this? I'm not getting those calls. I got a list, Dad. I'll go over those with you next week. I got a whole list.
It just hurts my feelings.
But he did such a great job. There you go, next to each other.
There.
Thank you. Every question I don't ask you about knee pain is a question I won't get from you about prostate problems and colonoscopy. So I'll consider it a fair trade. I want no part of that action.
There must be some very interesting times at your house when you're all
Right.
together.
Yeah,
I pity your mom and your wife.
yeah, as you should. Yeah.
That's probably when your mom goes out to the garden and says, yeah, I'm out of here.
Yeah, that's right.
Okay, well, thank you again so much.
You're very welcome. You're very nice. I appreciate the opportunity to speak to you guys. It's a great organization. It's very well run. You people are lucky in your community to have such a great organization providing this sort of information to you. So count your lucky stars. Thank you again for the opportunity.
A lot of this is thanks to your dad. He has been the
Yep.
person who's really championed this.
Way to go, Dad. Good job.
All right. Well, thank you.
Okay, good night,
All right.
everybody.
Yeah,
Thanks, everybody.
bye.
Have a good night.
Good night.
Night.
Thank you.
Thank
you.
you.